Hi, everyone. Good evening. Sorry not to be able to join you live to give this talk. I'm Richard. I'm one of the ST6s in 7. And I'm going to give a talk we call The Guideline Made Me Do It. And the idea of this one is just to run through what are recent or topical guidelines or consensus statement type things that have come out, which might be useful in the Viva, either to refer to directly or maybe more likely to give you some kind of structure or reasonable sounding things to say, particularly if you're faced with clinical scenarios that are not commonly within your area of practice. There are loads of slides in this presentation because obviously there are loads of guidelines out there. So we won't get through all of them within this kind of 40-minute slot, but the slides will all be made available to you through the Final Push system. And there'll also be a PDF or Word document that essentially lists all the guidelines that are mentioned and gives you a link so you can go and look at the source material or pull out the diagrams and things of whatever's helpful. So they're kind of grouped into different categories, starting with airway, obviously, because you've always got A always comes first. Then there's just a couple of newer ones that I want to highlight, which have come out since the last time this course and the last exam sitting was run. And then they're kind of grouped into various topics, and we'll just see what we can get through and take it from there. And as I say, there will be links available if anything's not clear, or if you want to go and have a look at any of the source material directly. So to get straight into it, we start with airway guidelines, and these are all based on DAS guidelines, a lot of which is familiar, I'm sure, but I think some of them are particularly helpful as there might be situations that you need to talk through and maybe even talk through in a way that makes you seem perhaps more familiar with the cases and procedures than you actually are sometimes. That was the case for me anyway. So the first one is the awake tracheal intubation guideline, which covers both awake fiber optic but also awake video laryngoscopy. But I'm going to focus on talking about the awake fiber optic side of things, because I think that's currently anyway, the more common technique, and one that you might feasibly refer to given a clinical scenario of predicted difficult airway. And I think the benefit of going through this guideline is that it just gives you a kind of very clear structure and almost like a cheat sheet to refer to, because I certainly found that I'd done, you might not have done very many, and you might have done all of them completely differently depending on who you did them with and what their preferred approach was. So this guideline just gives you a standardized approach, which I think is quite pleasingly simple, that you can refer to. It's set around this structure of stop, just to try and remember the key components of the procedure. And of note, they put the S for sedation with a little s rather than a capital, just to point out that in the most unstable or frail patients, the sedation aspect is optional, assuming that the topicalization part of it is done adequately. But it just is this kind of cyclical way of thinking about the procedure. And it does lay out some potential contraindications. The only absolute one is patient refusal. So it's unlikely that you'd have a scenario where you couldn't propose this as an airway plan, essentially. And I think the most useful part of the guideline is this diagram that just goes through each of those individual steps, and actually for all of them even gives you, the doses and how much and how many times to do things, which I found particularly useful. So if we start with the sedation aspect, most commonly using remifentanil, and it handily gives you an effect site to target, which I think is, you see all sorts of different things, but I think there you've got a nice single agent within this range to work on. Then in terms of the topicalization, this is a thing in particular where I had seen loads of different ways of doing it with loads of different adjuncts and sprays, gels, nebulizers. But this guideline just keeps it super simple. And essentially it says just use the lidocaine 10% spray. Use quite a lot of it, but just use the 10% spray. Plus, if you're going through the nose, which commonly we will be, then put cophenylcaine in the nose. But that's much more straightforward than trying to think about nasopharyngeal airways with gel on and all that kind of stuff. So I found that really helpful. And then the important bit is I think the testing of the topicalization. And they suggest using a soft suction catheter just in the back of the throat. And if that's well tolerated, then your topicalization is adequate. Having said that, if it isn't, they then give you the next steps to try, which essentially is use more sprays of that. And only then do they suggest that you might need to use a kind of spray as you go or lidocaine through the channel of the bronchoscope. And so in general, you can just get away with using this one approach with the 10% sprays. In terms of oxygenation, they strongly advocate for high flow nasal, which is much more effective than the kind of nasal sponge and oxygen tubing approach. And because the nasal prongs of the high flow are so soft and pliable, you can get the bronchoscope past them into the same nostril, and that lets you oxygenate very well all the way through. And then it just gives you kind of basic tips on how to actually perform the procedure itself, and in the full guideline, the sort of how you might set up the room and what the layout might be. Remembering about suctioning out before you start to clear secretions. And I think that just keeps it simple. You can rely to it quite easily and say that that's what you would do. It also then does give you some kind of troubleshooting tips if things don't go well, all of which I think are fairly straightforward. But the more useful bit, it might be to be asked, well, what if it doesn't work? What if you can't perform the procedure? And the main decision making that they focus on is, in that event, are you going to go straight for an emergency front of neck, or are you going to accept the fact that a normal GA would be high risk, but is the next appropriate next best step, which is maybe not an uncomfortable thing to then say when you've said you want to avoid that in the first place, but it just lays out the things you're going to consider and what your decision making might be at that next step should it fail. So I think the main advantage of that one for me was that I could just recite what they would say to do for the topicalization and procedural performance. So the next DAS guideline is an old one now, the Extubation Guideline, which I think gets a lot less focused than the difficult intubation guideline, but has certainly come up in the exam before, particularly in the written, but in the viva as well, in terms of what are you going to do at the end of this case. And much like the intubation guidelines, it's all based around these algorithms. And deciding for any given patient, am I low risk here, or am I at risk or high risk? And the low risk is the usual extubation. The at risk is the more interesting and perhaps the more likely thing that you would be asked about. And it essentially gives you these options basically. So you prepare to extubate as you would normally, but then these are the options that it gives you. So if you at a base level, you're deciding, is the tube staying in, is the tube coming out? And it lays out, if you are going to take the tube out, it lays out different ways you can do it, particularly things like an LMA exchange, leaving in an airway exchange catheter. So just to have some options of things you can refer to if you decided that you were going to extubate the patient, which leave you with a bit of a backup option. But then also, on the other hand, if you decide to leave the tube in, referring to this, you can say that, you know, that's completely reasonable thing to do. So that's just, I think, worth being familiar with, just because it's a kind of sometimes a neglected part of the anesthetic. And then the last one is the more recent one about neck hematoma after thyroid surgery, which came out fairly recently in response to some negative patient events in this context. And the main things I think that are useful in here are that it's focused, it's not just focused on anaesthetists, it's focused on anaesthetists, the surgical team, the recovery staff, the nursing staff who are going to be looking after these patients on the ward post-operatively, so that to try and get the whole team thinking along the same lines and looking out for the same things. So it gives in addition to doing kind of standard OBS, it says you should be looking out for these signs of impending airway problems, essentially, and accumulating hematoma. And it also kind of codifies this idea of having an emergency box at the bedside. So you would traditionally have something to remove the sutures, but this formalizes a bit more what would be in that emergency box that should be at the patient bedsides. And also, importantly, it says that all the wards where these patients are being looked after post-op should have front of neck kits available, which is not something that I think is widespread as of yet, but it's something that is now recommended in this guideline. And the important thing that I thought from the kind of classic DAS algorithm of what to do for these situations is that question number one, is there airway compromise? And if there is, just to remember that the evacuation of the hematoma comes above the intubation in the way they've kind of codified it. We naturally rush to think about securing the airway, but clearly with this potentially reversible cause of airway compromise, their focus is on getting that sorted first. So then you can have a phase of decision making about, okay, when and how is this patient going to go back to theatre? So just to remember that that's the way around that they put it. And they do also give a standardized approach as well with another mnemonic for how these hematomas should actually be evacuated. And I think the important thing to remember is just this idea that you're going to be cutting sutures and then open up skin in one direction, open up muscles in another direction. And in theory, that should allow you to evacuate. But that hopefully is going to be something that the surgeon who's been emergently called will be taken care of. But it just gives this quite nice kind of pictorial guide to the different steps. So that's the sort of airway guidelines and airway themes. I've next just got two that are quite new that I thought it was worth being familiar with, both of which are sort of addressing areas where there wasn't recent guidance before, and sort of formalizing things that were kind of already known to some extent. So the first one, the slide's yellow just to remind me that's one of the new ones, is about patients who've got advanced care plans or DNA CPRs or treatment escalation plans, particularly around CPR coming for anesthesia. And the recommendations it gives are fairly kind of common sense and in line with best practice that I think we'd all be trying to follow anyway. The main one, and the thing that I think we would normally have done, is this concept that a DNA CPR will be suspended while the patient's under anesthesia and then reinstated afterwards. But does say that that should be discussed with the patient. And they, in writing it, they kind of draw a distinction between CPR for cardiac arrest versus giving a short period of chest compressions specifically to circulate drugs. So, for example, with a severe bradycardia, giving chest compressions to help circulate atropine or to help circulate adrenaline. In their eyes, that is a qualitatively different thing. So it's kind of doing that doesn't contravene a DNA CPR in their eyes. Similarly, a patient who went into sudden arrhythmia, which needed defibrillation, which can be done very quickly, they draw out as a slightly distinct circumstance that would be permissible. And the main thing is that if you as an anesthetist feel you cannot, in good conscience provide the anesthesia for whatever procedure the patient's having and go in line with their wishes, for example, they wouldn't want any kind of resuscitation attempt in any circumstance, but it's an extremely high risk procedure. If you're not okay with that, then it does give you the option of seeking further senior opinion in that case around the decision making. So I think largely that just codifies what we kind of have learned to say is the answer anyway, of in general, suspend the DNA CPR for the time of anesthesia. And the next one is about it's about pacemakers and ICDs, basically, and what to do with them under anesthesia, which is sort of an update of an existing guideline from the British Heart Rhythm Society. And it's got some really useful tables basically within it to kind of tell you what to do. The main focus being when you need to involve a pacemaker or cardiac technician and when you don't, depending on the individual patient and the type of device. So they give general precautions, which I think we're all familiar with, from learning about the diathermy and all of that. That obviously patients should be monitored, putting diathermy plates as far away from devices as possible, and encouraging the surgeons to use short bursts of diathermy, and making sure that emergency equipment is available. So that'll be a clinical magnet, a defibrillator, plus or minus having pads on the patient. And all of this is to try and avoid the electrical interference from diathermy of the pacemaker detecting that as activity, and essentially then the pacemaker being inhibited because it thinks there is electrical activity coming from the heart. It just confirms that the preferred or ideal placement for defib pads is anterior-posterior, with the anterior one as far away from the device as possible, but also makes the point that the device might not necessarily be directly under where the scar is. So just make sure that you palpate where the actual device is in terms of optimizing your pad placement. And that, defibrillation through this kind of setup should not cause any damage to the device. And also that if any internal defibrillator were to go off, that's not potentially harmful to you as the anaesthetist if you're, touching the patient or near the patient. It then goes on to try and clear up what the effect of putting a magnet on is. Because I kind of remember being taught that if you put a magnet on, it would completely knacker all the settings of a device, and it would have to be completely reset again from scratch. But that is not the case. So any response is temporary, and when the magnet is removed, it will revert to the settings it was on before. they make the quite pragmatic point that you need to make sure that the magnet is firmly secured over the device to the patient, i.e. taped on, because obviously it's only working as long as it's there. And they do warn that application of the magnet might cause the device to emit quite a loud auditory alarm, but that's nothing to worry about and to be expected. As I say, they say consider also, if you're using a magnet, consider having pads on. And it lays out what the device will do in response to the magnet. So if it's just a pacemaker with no defibrillatory function, the magnet application will put it into a fixed rate pacing mode. The benefit of that is that it's not looking for any cardiac stimulus, so it won't do anything in response to diathermy or other interference. But the potential theoretical downside is that you have the risk of the R on T phenomenon where it tries to pace on top of a native beat. But it's thought that the risk of that is low in practice. On the other hand, with something with a defibrillator function, so an ICD, the application of the magnet stops the defibrillation function, and it stops any anti-tachy therapies, which again is defibrillation when a tachycardia is detected. But in contrast to a pacemaker, the magnet doesn't affect the bradycardia pacing features. So any underlying pacing, including in response to electrical interference, is not affected. It's only the shock function. And these are the ones in particular where it's advised to have pads on until such time as the device is reactivated by taking the magnet off. And it's easier to look at in the guideline itself, but they essentially give you these nice tables, the underlying point of which is to highlight when you do need to speak to a pacemaker or cardiac technician and have the device reprogrammed for the course of the procedure. And essentially, my take home from it was that a lot of the time that isn't necessary because the risk of interference is low. The consequence of interference is low, and also the magnets can often do the job. So with all kinds of devices, the main question is this patient pacemaker dependent? I.e., if they're not paced, is their intrinsic rhythm so slow or unreliable that they won't have an adequate cardiac output? And actually, if patients only have a pacemaker and they're not pacing dependent, all they actually advise is that you monitor the patient just to make sure that there's no instances of the pacemaker being inhibited. If it is, it's likely only to be for one beat, which in general won't cause catastrophic compromise. So no reprogramming, i.e. the cardiac technician coming, no reprogramming is actually necessary for these devices in general. If the patient is pacing dependent, then they draw a distinction between where the surgery is in the body. So below the umbilicus, it's essentially the same guidance because the risk of interference inhibiting the pacemaker is low, but they do suggest in these cases having a magnet available in case you do start to see that, and then you can switch to the fixed rate pacing with the magnet. However, for those who are pacing dependent, for surgery above the umbilicus, if there's going to be prolonged diathermy, they do suggest that it might be worth getting the device reprogrammed for the procedure. With the ICD devices, it's slightly different, but again, for surgery below the umbilicus, they actually say it's fine to leave it as it is because the chance of it being triggered is very low. And also the effect, if it were to be triggered, the effect on the patient is relatively low. So they say that you can just monitor, not get any reprogramming of the device, and just have the magnet available if you need it. But for surgery above the umbilicus, where it's more likely that it might be triggered, they do recommend deactivating the ICD. In someone who's not pacing dependent, you can just do that with the magnet, because as we've seen, the magnet won't affect the pacing function. But if they're not pacing dependent, then that's okay. For those who are pacing dependent, they recommend that maybe those you would want to get the text to reprogram it, or use a magnet if you don't think there's the risk from prolonged diathermy of inhibition of pacing, basically. So that's a kind of summary of the tables that are in there, and yeah, kind of just clears up what magnets will do and the kind of considerations you might want to make in different settings. So those are the new ones. These next ones are just sort of general guidelines, a lot of which I think are quite familiar now, but are just around sort of good practice and recommended standards that we should be meeting. So the first is the classic standards of monitoring guideline. In some form, these have been around for a long time, but there was an update last year, which did have some fairly major changes from the 2015 guideline, particularly around the things listed here. So I'm just going to go through and predominantly pick out the things that have changed, some of which have caused a bit of controversy in terms of putting them into clinical practice. So for general anesthesia, we're all familiar with this kind of standard full AAGBI monitoring. But what's new is that it's now written that all of that monitoring, including the capnography, should be continued while patients are transferred from theatre to recovery. That does happen in some centres, but in some centres, often patients are completely unmonitored in that phase. But according to the guidance, the standard of monitoring shouldn't change when you leave theatre to transfer to recovery. And the other aspect is around capnography in recovery. So essentially, if patients are going to recovery with supraglottic airways still in situ, or in some places with endotracheal tubes to be extubated in recovery, then capnography again should be ongoing. And that's something in particular that has been difficult to implement in recovery in a lot of places. But that is the standard of monitoring, that the capnography continues until the airway is out and the patient's awake, essentially. In terms of regional, not much has changed, but it does just clarify that you can delegate the monitoring of a patient who's fully under regional anesthesia as opposed to any sedation. The person or anesthetist who did the block should be immediately available for a quarter of an hour and then within 2 minutes for the rest of the case, but that monitoring can be delegated. Procedural sedation, it just clarifies that if you're into the kind of deep sedation territory, capnography should be used. And then transfer is similar to the kind of the GA transfer to recovery concept. The monitoring on transfer should be the same as in theatre. So the capnography should be continuous for both anesthetized and sedated patients. They also now have more on the use of quantitative neuromuscular blockade. So essentially, as far as the guidelines are concerned, qualitative monitoring with just, for example, just visual trainer 4 is not recommended. We should be using quantitative monitoring with the accelerometers on the finger whenever anyone's paralyzed. It should, in best practice, be started before the drugs are given, and they define full reversal or recovery's function as that trainer 4 on the quantitative measure being greater than 0.9 to define, adequately reversed. They also added a bit more about the use of processed EEG, BIS or entropy, and formally say that when we're giving TIVA with paralysis, it should be used. I think that's fairly common practice now anyway, but that it should be started before any drugs are given and continued until you've got that quantitative recovery from the paralysis. And then there's just a brief thing about blood glucose, confirming that we should be checking it at least every hour in diabetic patients. And you should also have access to essentially point of care blood gas and hemoglobin testing, as well as the availability of bronchoscopy. So that's just the update to that guideline. The other one is the, again, a few years old now, but the one that kind of codifies best practice for TIVA, and just lays out what we should be doing to make sure that we're doing TIVA to an appropriate and safe standard. Again, a lot of which is now quite common practice, but may need to be spelled out in an exam setting. So in general, we should be using formal TCI pumps, well, formal TCI models within our pumps, as opposed to manual infusions or the sort of older infusion regimens. And just as a way of trying to avoid the wrong drug being in the wrong pump, program the pump after the syringe is in there. It still doesn't obviously completely prevent mistakes, but it's a step to try and mitigate. And then they make that other point about the fact that if you're paralyzing, you should be monitoring the EEG where possible. In terms of the practicalities of kit and delivery, they lay out the characteristics of a proper TIVA giving set, namely that it's Luer lock at both ends and has the appropriate valves to stop reflux and accidental drug delivery. And that, of course, wherever it is possible or practical, the cannula should be visible. So those are just a couple of kind of best practice things. The next section, we'll just try and get through a couple of specific patient groups for whom there are relevant guidelines or resources, and just as much as anything else, this is just about kind of signposting to these resources, but also having something to say if this is one of the clinical scenarios that you face within one of your cases. So the first thing is around obesity, and I think we're all familiar now with the SOBA guidelines, which again have been updated a couple of years ago, and it lays out these kind of general best practice and logistical things that you might want to do, things like positioning, things like in general, the type of anesthetic that you might want to give to these patients. You know, consider using regional. Things are going to be more difficult, which is helpful as kind of general tips. But then I think the main useful thing in this is the old table of which drugs get dosed on which body weight. So, you know, what's on total, what's on lean, and then what's on typically the kind of propofol ideal plus 40%. And that, you know, that can feed into that discussion of, well, how are you going to program your propofol TIVA for an obese patient? What weight are you going to use? And you can talk around the fact that this is recommended, but, you know, alternatives are to use different weights and titrate to effect and so on. But I think this is just a useful thing to have to refer to. The other good SOBA thing, which a lot of people do have now, is the SOBA app on your phone, which will essentially help to figure all this out for you. So, you know, it'll calculate these different body weights for you and give you doses for things. Obviously, I don't think you can yet whip out your phone in the Viva, but in clinical practice, I think it definitely takes a bit of the cognitive load off. The next one's around diabetic patients. And there are actually lots of guidelines now on diabetes. There's an association one, but this Centre for Perioperative Care one is more recent. So that's the one that I've been referring to since it came out, essentially. It gives general guidelines around essentially which patient should have referral to the diabetic team ahead of surgery, and that's those with poorly controlled diabetes or who have insulin pumps. As with the monitoring guideline, we should be checking the glucose before we start, and then every hour if they're on insulin, otherwise 2 hourly, whereas the other guideline just said check hourly. And the target we should be looking for in theatre, if we are checking it, is between 6 and 12, so it's a slightly more relaxed upper limit. And the focus, I think the focus of the guideline is more on avoiding hypoglycemia, and it's a bit more relaxed at the hyperglycemia end of the spectrum. And it goes through in quite a bit of detail what to do for different patient groups and, you know, when different interventions are indicated. So for example, the variable rate intravenous insulin infusion, it lays out which patient should have that, which in general is type 1 diabetics who aren't having their background insulin, or anyone who's having a prolonged fast, and also most cases of emergency surgery where hormones and stress response and sugar control and oral intake are more likely to be disrupted. And it does also just give a reminder that alongside this, patients should be having 80% of their usual dose of long-acting insulin while they're on the variable rate infusion. And they give the kind of ideal fluid regimen to run alongside it, which is the kind of 5% dextrose and half normal saline, which isn't always available, but that's the kind of gold standard. But it just puts in the reminder that for these patients, because they're having insulin, you have to also keep giving them some glucose containing solution to minimize the risk of hypoglycemia. And obviously monitoring and titrating of these in line with local protocols. They also give treatment plans for hypoglycemia, which they define as a glucose less than 4. And essentially through one form or another, they recommend a dose of 15 to 20 grams of carbohydrate, which most typically they recommend using 10% at a kind of 200 ml bolus dose, which will be 20 grams. On the flip side, they also give a little kind of ready reckoner to treat hyperglycemia. So they define that as more than 12. If it's up more than 13, they suggest checking the patient's ketones. But it gives you this nice kind of dosing guideline for, you know, Act Rapid or some other similar insulin. So you'd expect a dose of 1 unit to give a reduction of 3 in a type 1 diabetic. So, you know, pick 2 to 6 units accordingly. And for a type 2, they recommend dosing at a sort of 0.1 unit per kilogram to try and get an adequate response, basically. They then just give some practical tips on what to do for patients with insulin pumps, which I think is going to become more common in clinical practice. Step 1, make sure that it is where it should be, the cannula's in and it seems to be working. And then you're going to check their glucose quite frequently, titrating if needed, and similar to a pacemaker, you know, keep the diathermy away from the device. And if they're persistently running sugars above 12, then assume that the device has failed and switch to add in a variable rate intravenous insulin infusion, as you would otherwise. And the final thing, this is just kind of to signpost it, is that much like some of the other guidelines, it's got a table of what to do sort of electively, what to do with all the oral anti-hypoglycemics, which I think this one is a bit more straightforward and a bit more helpful maybe than some of the others. I think the kind of topical one has been the SGLT2 inhibitors, the flozins, and this risk of developing acidosis with them. So they should be omitted the day before surgery, whereas all the others are taken as normal the day before surgery. So just to point that out. And then I'll just quickly point you to some things in this dementia guideline, and then we'll wrap up after that. But there's an association, there's an association dementia guidelines. A lot of it is kind of general good practice points that we learn about avoidance of delirium and that kind of thing, making sure that we involve people who know the patients well and do what we can to disrupt their baseline cognition and behavior as much as possible. Good practice like orientation and things. But the main thing that's useful in the guideline, I think, is when it talks about drug interactions between anesthetic drugs and common dementia drugs, particularly patients who are on cholinesterase inhibitors, which will interact with neuromuscular blockers. And they kind of say that on an individual basis, you just should decide what you're going to do about neuromuscular blockade, because it doesn't work as expected sometimes. And it gives you this, I think, again, the tables in these things are really useful. So it kind of gives a guidance for what you should do with some of the more common medications, and also how you should deal with it if the patients are taking them. It gives these nice kind of orientation guidelines in terms of the whole perioperative journey, how to best look after these patients. And it gives a recommendation that we should probably be avoiding, I think a lot of which is already in fairly common practice, but avoiding benzos, cyclazine and tramadol, partly because of direct effects on cognition potentially, but also because of the kind of drug interactions. And the last one I'll just point at and just give you show you the table from is about patients who are on steroids. It's quite a common scenario we're faced with. Important points, I think, are that it defines sufficient steroid intake that could result in adrenal suppression as being a dose of at least 5 milligrams of prednisolone for a month, so not a particularly high dose. And in general, if you think they might be at risk of adrenal suppression, give them some steroids perioperatively. And what they recommend most of the time is a 100 milligram bolus of hydrocortisone at the start. Keep some post-op replacement going until they can take oral, often at double their usual dose, and then aim to taper back to normal. And again, I'll not talk through them, but they include tables specifically based on whether it's primary adrenal insufficiency or steroid related. And it gives you these kind of protocols to follow. And I think one of the most useful things is that it does confirm that not necessarily for the primary insufficiency, but for the glucocorticoid induced cases, that a decent dose of dex in theatre will cover you for the first 24 hours. And the last little patient group, just to mention, is there is this breastfeeding guideline, which I think has been a bit of an underlooked area of practice. But in general, the advice is that the express and discard or pump and dump approach is often not required, because almost all the time you can breastfeed as normal after surgery, because almost all the drugs we use haven't been shown to have any negative effects. The main one to watch out for is codeine. That shouldn't be used because of its metabolites, but the dihydrocodeine is okay and is safe to use, and is often in the sort of enhanced recovery after cesarean section protocols. But almost all the other things that we would tend to use, you can breastfeed as normal after. But they do just say with tramadol and high doses of oxycodone, just make sure that the baby can be monitored. But yeah, codeine and aspirin at high doses, not the sort of 75 milligram antiplatelet dose. High dose aspirin should be avoided as well. So we'll stop there. A bit of a whistle stop through some of the guidance out there, particularly most recent ones, and some that I think are potentially exam related scenarios. As I say, the slides will be available, and there's a PDF with a link to all the guidelines that you guys can access as well. Hope that was helpful. Thanks very much.